Hello, everyone, and welcome to another edition of the Cheraram's Diabetes Institute's Diabetes Update. And today I'm going to talk to you about how we can empower organ protection as standard of care in type 2 diabetes. And I'll be giving you some current perspectives on the use of a drug class called the sglt2 inhibitors. Now, the Indian patients are somehow very different from what we see in the West. And we have heard for several years now that Indians have what is called the thin fat Indian phenotype, and they have a premature cardiometabolic risk. What does this thin fat Indian phenotype really mean? So if you look at the Indian diabetics, their age of diagnosis is 10 years earlier, so a decade earlier. If you look at their BMI, they are at least 4 to 6 kilogram per meter square less than what is reported in the West. And they have a mid-arm circumference, which is about 20% lesser than the Western counterparts, in which sense we say that we are thinner patients because mid-arm circumference is a marker of obesity. But on the other hand, if we see, in terms of the waist-hip ratio, we are at least 5% over the Western counterparts, that we have more fat in the waist region. If you look at the subscapular fat versus the triceps fat, again, a measure of the body fat percentage, we are at least 20% higher. The total fat percentage in terms of weight, how many percent of the body weight is actually fat, we are at least 30% higher. So for each kilogram of body weight, we have 30% more fat. And all this actually translates into 1.5 times more insulin resistance. So we may have less generalized obesity and thinner limbs, but higher adiposity. That means overall body fat is high, and most of this body fat is actually concentrated around waist, what we call central adiposity, and therefore we are more insulin resistant. When we are looking at a diabetic patient over his overall lifespan, we often pick up patients who we detect in the pre-diabetes or the very early diabetes stage, where they still do not have established complications, but they already are showing some risk factors, which could be slight hyperglycemia, increased weight, slightly increased blood pressure and lipids, and an overall increase in the cardiovascular risk because they are diabetes. In some patients, we may even see that microalbuminuria has begun to set in. Now, of course, we need to control these traditional risk factors, but then there are many more which we do not measure directly. So the genes, which are very peculiar to the Indian subcontinent, the environment, which means the lifestyle, the type of diet that we consume, the insulin resistance, which I said already is higher in Indians. We also have a makeup of genes which makes beta cell function less efficient than the Western counterpart. So even at the pre-diabetes stage, our insulin production is lower. We may have other endocrine problems, neural and metabolic disturbances. We already have visceral adiposity. The inflammation levels and the reactive oxygen species may be higher. Possibly one of the mechanisms could be increased environmental pollutions. And there is some role also of the microbiota, and that is also coming through the number of drugs that we use, the number of endocrine disruptors, the type of diet that we use, etc. And then also, of course, what is meant by gluco and lipotoxicity, which means that excess body fat itself is more damaging to the body in terms of insulin resistance. From here on, we move on to the advanced type 2 diabetes, where we not only have established hyperglycemia in the face of insulin resistance, but we also get obesity, dyslipidemia, the non-alcoholic fatty liver disease, and NASH. And we start getting the cardiac problems like atherosclerosis, heart failure, acute coronary syndromes, hypertension, increased coagulable states, And we have the third important problem, which is renal, which means that there is a drop in the EGFR, albuminuria progresses, hemoglobin becomes lower, electrolytes get disturbed, and so on. So, from this initial area of slight risk factor control, if we don't act early, we now move on to the overt, complicated type 2 diabetes, where we not only have to manage risk, but we also have to manage end organ disease. Today's talk is actually about empowering metabolic foundation in type 2 diabetes with SGLT2 inhibition. Now, if you look at SGLT2 inhibitors, they not only reduce fasting and postprandial glucose and HbA1c, but it's also important that they are they have long durability. That means they continue to be effective for a long time, independent of beta cell. So even as the beta cell function is reducing, they still continue to modify hyperglycemia. Not only that, because they do not secrete insulin, they have lower risk of hypoglycemia and improved time in range, because the nadirs and the peaks are blunted off because of this particular drug. And if you look at the SGLT2 inhibitors in type 2 diabetes care, we also know that they are capable of reducing ectopic and visceral fat and improving the adipokine profile, because the fat is reduced, therefore the production of hormones from the fat is reduced. So what we call dysfunctional adiposity is actually reduced. And on the other hand, they improve insulin sensitivity, they improve the metabolic profile, they reduce insulin resistance, and they also reduce insulin requirements. They are not just acting on fasting and PP sugar, but they are also doing a lot of things independent of beta cell function and with long durability. So I think this is a very important point to note. If you look at glycemic efficacy in Indian patients or Asian patients as compared to the West, you know that in Asians, the SGLT2 has a much better propensity to reduce the HbA1c as compared to whites. And this was also seen in the case of DPP4 inhibitors in Asians. This may have to do with the race, the genes, the type of insulin production, etc. But clearly, these molecules are more efficient in Indian populations than in the Western populations. As I was saying, the SGLT2 inhibitors not only improve fasting and PP, but what the concept nowadays is that you can't really have each and every sugar perfectly within the normal range all throughout the day. So we talk about time in range. And if you see here, as compared to placebo, if you see empagliflozin, if you continuously use empagliflozin, from 55% time in range, we go on to almost 81% time in range. And the gold mark or the gold standard is that we should have at least 70 to 75% time in range to call it a meaningful response in hyperglycemia reduction. So again, time in range metric also improves significantly. I was talking about longer durability of glycemic control. Now we know that metformin has approximately a 5 years time to A1C neutrality. That means it starts failing over 5 years. Sulfonylureas and DPP4 inhibitors have the shortest time to A1C neutrality, ranging between 3.3 to 4.4 years. That means they tend to start failing at this point of time. But the SGLT2 inhibitors and the thiazolidine classes have time to A1C neutrality between 6 to 8 years. So they continue to remain effective for almost 6 to 8 years, which is a huge sum. And in our practice, in day-to-day practice, if we have a drug which continues to remain active and stable for 6 to 8 years, this is fantastic result. Not only does it reduce sugar, but you can see here that as compared to sulfonylureas, it causes weight loss also. And the average difference in weight is approximately 4 to 5 kilos. And this weight is predominantly lost through the central fat, thereby improving the adipocytokine profile. There are a number of inflammatory hormones which are secreted from the fat tissue. And because the fat tissue is reduced, the adipocyte production of these hormones is less. And at the same time, Because the fat mass is stabilized, a useful hormone, which is called adiponectin, which is a direct marker of insulin sensitivity, tends to improve. So you can see here the difference between empagliflozin and sitagliptin, where adiponectin levels are rising, which means that the insulin sensitivity is improving. This is a very elegant study looking not only at the fat, but also at how the brain insulin sensitivity is working. And this is a very important concept. And you will see here that there are very few drugs which do it actually. But empagliflozin clearly improves the hypothalamic insulin sensitivity. Also, of course, the overall insulin sensitivity, which we measure by HOMA-IR and the fasting immunoreactive insulin, clearly improves. You'll see that the HOMA-IR from baseline to week 12 clearly improves. That means the insulin resistance is improving. This is not seen in placebo. And the fasting immunoreactive insulin actually tends to dip. Why? Because less insulin needs to be produced by the body because the insulin resistance is less. Because the insulin sensitivity is more, less insulin is required to be secreted by the pancreas to keep the sugars normal. As I was saying, empagliflozin acts on the overall fat content. But what we now see as a very important complication in type 2 diabetes is the liver fat content, what we call NAFLD or NASH. And in this ELIF study, which is a randomized controlled trial of patients with type 2 diabetes and NAFLD, you see here that empagliflozin actually reduces in a very statistically significant manner the content of hepatic fat. And I think this is a very important issue because this NAFLD is one of the most important markers now of chronic liver disease in diabetic patients. SGLT2 inhibitors and also the GLP-1 receptor agonists improve biomarkers of hepatic steatosis and fibrosis in patients with T2DM and NAFLD. And this is a study in advanced liver fibrosis where the FIB-4 score was quite high, more than 2.67. In controls, as you can see, there was no difference. There was no difference with DPP-4 inhibitors. But in both groups, GLP-1 receptor agonists and the SGLT2 inhibitors, there is a very statistical significance in even the advanced liver fibrosis. So the liver fibrosis tends to reverse a little bit with this group of agents. Not only does it cause reduction in hepatic fat content and the enzymopathy, but even causes a decrease in the liver fibrosis. Another important problem that is associated with obesity and type 2 diabetes is new onset of obstructive sleep apnea. And you will see here from the EMPA-REG outcome, the new onset obstructive sleep apnea in patients with type 2 diabetes is reduced by 52%. And you know that obstructive sleep apnea has its own complications in terms of cardiac problems, arrhythmias, sudden cardiac deaths, and so on. So this reduction of new onset of OSA is a very important thing. We also know now that SGLT2 inhibitors improve kidney outcomes in patients with type 2 diabetes. And this kidney outcome is consistent. The benefits are consistent across baseline eGFR values. So overall, if you see, there is a definite improvement. But when you go from very good eGFR of more than 90 to moderate renal failure of 30 to 45, we see that the improvement in renal markers is consistent and uniform. It doesn't mean that you have to wait for renal failure to occur before you start SGLT2. Even at a eGFR of 90 plus or a moderately reduced GFR of 60 to 90 or 45 to 60, still continue to see improvements. We already know that SGLT2 inhibitors have a very definite effect, a very definite positive effect on heart failure. And there are many mechanisms for that. Not only do they reduce load by increasing the free water clearance, decreasing the in-stress blood volume, decreasing the pulmonary vascular pressures and the intraglomerular pressures, but they also have an effect on afterload by reducing the vascular stiffness, causing a reduction in the neurohormonal stimulation and change towards positive in autonomic balance. But what they also do, and there is a lot of studies on this now, that they improve cardiac structure and function. By that, I mean that the actual myocardium becomes more metabolically efficient. There is better relaxation in diastole. There is an increase in oxygen demand and supply balance. There is a reduction in LV hypertrophy, and there is a betterment towards LV remodeling and fibrosis. So not only is there a change in the blood vessels and the blood volumes, but there is also an actual change in the pump itself, where the pump becomes much more efficient. We also know that treating with empagliflozin also causes moderate but very significant reduction in systolic and diastolic blood pressure. So adding to all the factors that we said earlier, we will see that empagliflozin has this another mechanism of improving the heart outcomes. Up to now, it was thought that empagliflozin will be useful in CV safety only if you have established atherosclerotic cardiovascular disease. But this meta-analysis of 7 phase 3 studies, which does not include EMPA-REG, which, as you know, all the patients were established ASCVD, you will see that regardless of the prior absence of established coronary artery disease, peripheral artery disease, or cerebrovascular disease, you can see here that only 15%, 3%, and 5.2% had these problems. You still saw that CV death or hospitalization for heart failure events were significantly reduced, and the risk reduction, the hazard risk was 0.45. Very, very important. Clear 59% reduction in these risks. Empagliflozin also offers, as we know, reduction of CV death. And it's very interesting to note that we don't have to wait till 3 years or 4 years to see this benefit. If you see these lines start to diverge almost at about 6 months, that means just at 6 months, we see that the benefit starts to accumulate. In the overall study population, this was about 38% relative risk reduction. But as I said earlier, the Asian patients do better. And in Asian patients, the relative risk reduction was 56%. So in our country, where we are treating Indian patients, this becomes very important. So empagliflozin reduces the risk of not only the first CV event, which is of course important, but also we know that recurrent CV events means more number of opportunities for the heart to get damaged. And we also want to prevent these recurrent CV events. And here you will see that as compared to placebo, major adverse CV event, what we call the 3P MACE, or the myocardial infarction, or the myocardial infarction of coronary revascularization, if you look at this forest plot, in all of them, you will see it is favoring empagliflozin because the risk reduction is up about 20 to 20%. And all of these values are statistically very significant. So it's not just the first reduction, but also the recurrent events which are prevented. In patient subgroups with atherosclerotic CVD and type 2 diabetes, if you look at the major comparisons between the different types of gliflozins that we have, you see that the EMPA-REG outcome results in meaningful reduction of major adverse cardiac events. This is, of course, in patients who have had prior adverse CV events. This was seen very definitely with EMPA. But of course, because of the nature of the trials, it was not very well seen in DECLARE. If we look at cardiovascular death, a very substantial reduction seen only in the EMPA-REG study and not in any other study that was seen, whether it was CANA, whether it was DAPA, or whether it was ertugliflozin. And hospitalization for heart failure, however, seems to be across the board, whether you use EMPA, whether you use CANA, whether you use ertugliflozin or dapagliflozin, this one effect seems to be the class effect. the heart failure reduction, but the cardiovascular death and prevention of major adverse CV events, the first event and the recurrent event, seems to be very specific for empagliflozin. And if you look at the benefits for heart failure, again, it's very important to note that this benefit is seen across the CV risk continuum. That means it will definitely be seen when you have reduced or what is called the HEF-REF, that means reduced ejection fraction. There, of course, it will be very clear. But even at the lowest risk, that is low to medium CV risk, you will still see a 59% reduction in risk. In ACVD without prior CV event, also you will see risk. In ACVD with prior CV event, you will see the risk. You will also see this risk reduction in what is called heart failure with preserved ejection fraction, or even when there is heart failure with moderately reduced ejection fraction. So across the board, right from a low risk category, the highest risk category, across the board, you will see that there is reduction in CV death or hospitalization for heart failure. Now, on top of the glycemic benefits, there are several other non-glycemic benefits. If you take 100 patients with, say, coronary artery disease and type 2 diabetes and treat them for 3 years, what all benefits will you get? You will prevent in CV events. You will prevent almost 8 to 9 CKD events. You will prevent about 3.4 events related to AKI and acute renal failure. You will see that in about 12.9, the insulin requirement is actually reduced. You will see that the systolic blood pressure goal is achieved in about 5 additional cases in patients with resistant hypertension. You prevent 6 new cases of obstructive sleep apnea and edema. And what do you mean? What does it mean to the patient? 3.4 total additional life years gained. So it's not just about fasting and PP. That is what we were talking about, giving it a meaningful organ protection, not just hyperglycemia reduction. So if you look at the European Society of Cardiology guidelines, in patients with type 2 diabetes and high CV risk, what we say is the risk of major CV events is significantly reduced by empagliflozin, and risk of CV death and all-cause mortality is reduced. Risk of CV death or hospitalization for heart failure is reduced, and also risk of kidney disease progression is significantly reduced by empagliflozin. So the major complications that we fear, that is the myocardial events, myocardial infarctions, cardiovascular death, heart failure, and kidney-related events, all are reduced in these patients. And therefore, if you look at the ADA standards of care, the 2022 guidance, you will see here that if there is a CVD or indicators of high risk of heart failure or CKD, what we need to do is to start clearly a molecule of sglt2 with proven CVD benefit. And this is especially more so if we are dealing not just with ASCVD, but with some degree of heart failure and CKD, because this is the drug which will actually protect these two very important organs, that is the heart and the kidney. And the guidance further says that if you look at CV effects and renal effects, what we need to know is that sglt2 inhibitors are the real drugs which actually benefit not only ASCVD patients, but also heart failure patients, and also influence progression of DKD. And this is in direct comparison to the GLP-1 receptor agonists, which do benefit ASCVD, but they are neutral as far as heart failure is concerned. And the benefit actually in diabetic kidney disease is not as great as seen with the sglt2 inhibitors. If you look at another guideline coming from the AACE, what it says is that independent of glycemic control, if you are getting a patient with ASCVD established or high risk to develop ASCVD or CKD grade 3, stage 3, or HFrEF, please start GLP-1 receptor or sglt2 inhibitor with proven efficacy. And then, as monotherapy also, and then if you require additional drugs to control their blood sugars, then you can use other therapies like adding on metformin, adding on sulfonylureas or GLP-1 or insulin or whatever seems to be the most appropriate thing. But this is a very substantial change that for patients who are at high risk to develop these problems, you can now consider empagliflozin as the starting monotherapy and then add on other drugs. So this is what I started with, empowering risk factor control and target organ protection. So as we looked at the risk factor control, effective across different A1C levels, low risk of hypos, long-term durability of HbA1c control, improvement of in-time range, reduction in adiposity, inflammation, and blood pressure, improvement in insulin sensitivity, all the risk factors which cause a progression to target organ damage are already being modified. And when you already have established target organ damage, what the sglt2 inhibitors do is reduce the risk of major adverse CV events, reduce the risk of cardiovascular death, they reduce the risk of heart failure events, reduce the risk of kidney disease, and they reduce the hepatic fat and the NAFLD outcomes. So I'll stop here and thank you very much for allowing me to share my thoughts.